Okay, let's talk about this cool patient. This was a 28-year-old male who presented with sore throat, trouble swallowing, and fever. He was becoming increasingly hoarse and was only able to swallow liquids when he arrived in the emergency department. He denied any neck stiffness or neck swelling, any neurological or dermatological symptoms, or essentially anything else. He has a history of insulin-dependent diabetes. He has not had surgery. He doesn't smoke. He has recently immigrated from Mexico and is unsure about his pediatric vaccine status. On exam, his heart rate is 100, his blood pressure is 145/85, his respiratory rate is 22, O2 sat 100%, and he is febrile at 102.9 Fahrenheit. He is pleasant, well-appearing, and obese. His oropharynx exam is basically normal. It's pink, moist, without exudates or tonsillar edema. Uvula is midline. His neck has some right-sided cervical lymphadenopathy, and there is some tenderness along his cricoid cartilage. Otherwise, his neck is supple. His lungs, cardiovascular, gastrointestinal extremity exam are essentially normal. Some labs are obtained in the emergency department which show a white count of 25,000 with a neutrophil predominance. And then on the right side of the screen, you can see a lateral C-spine film. Okay, so here's the cervical vertebral bodies and the spinal column. You're catching some of the mandible here at the base of the skull, but what we really want to look at is this is supposed to look at his airway. This is posterior oropharynx coming down. This is his epiglottis coming down into his trachea and into his main stem bronchus. And so what you see the arrow pointing at is this very enlarged epiglottis here, the so-called thumbprint sign, which you could infer is basically the size of a thumb, or looks like a thumbprint is being pushed here. You see the cricoid cartilage and hyoid bone here as well. Note that there is no paravertebral swelling here. Okay, so let's talk about epiglottitis, which is what that x-ray showed. It is inflammation of the epiglottis resulting in a rapid onset of life-threatening airway obstruction and is an ENT or otolaryngologic emergency. It presents with 1 to 2 cases per 100,000 adults, and although historically considered to be a pediatric illness, its incidence is actually higher in adults at this time. Increased risk with areas of low Haemophilus influenza vaccination, and the most common pathogens are Haemophilus type B, beta hemolytic strep, and certain viruses. Differential diagnosis includes, but is certainly not limited to, strep pharyngitis, tracheitis, mononucleosis, laryngitis, bronchitis, other viral syndromes, neisseria, gonorrhea, diphtheria, angioedema, peritonsillar abscess, retropharyngeal abscess. Presentation is classically a triad of drooling, dysphagia, and distress, the so-called 3Ds. Kids are more likely to have some sort of tripod positioning. They're kind of leaning forward with their neck extended. About 75 to 94% of patients present with a sore throat, and almost all of them present with painful swallowing. Stridor would be the feature that is most concerning and suggests imminent airway obstruction and should be considered an emergency, often requiring airway or endotracheal intubation. Less common in adults than in kids. Here on the right, you see an illustration of a normal epiglottis right here, and then this is the sort of the vocal cords and the arytenoids descending on the airway, and here you see an inflamed epiglottis. Okay. So diagnosis is really a clinical picture with some sort of imaging, which was classically the lateral neck radiograph. If you can get a CT scan, it certainly gives you a lot more information and excludes other diseases. It is considered an ENT emergency. You should consult ENT if you're really worried about it or you know that that's the diagnosis. And the gold standard is visualization with nasopharyngoscopy, which allows you to intubate from this view if you want. So here again is the epiglottis. Okay, it is massive. You cannot really see past it except for maybe 10% of the airway here, which would typically be quite patent. So managing the airway is the #1 priority on initial presentation. You, of course, need to give them antibiotics that cover for H-flu and strep, among others. You should also consider steroids and nebulized epinephrine, which can both help with edema. And then if you are going to intubate them, you should do it awake and sitting up with a surgical airway kit at the bedside. In the case of our patient, his x-ray did show a thumbprint sign. He was able to obtain a CT scan. This is a different patient, but the same idea. You see a massive epiglottis here, okay? But there's no retropharyngeal abscess or peritonsillar abscess or any other infectious findings. ENT was emergently consulted and came to bedside where they did nasopharyngoscopy, which showed the cherry red epiglottis obstructing the majority of the airway. He got ceftriaxone, dexamethasone, and fluid bolus in the ED. He was admitted to the ICU for airway watch, but was not intubated. He did very well, was discharged a couple days later on oral antibiotics. So, briefly talking about epiglottitis, it is an ENT emergency caused by inflammation of the epiglottis, which can lead to rapid onset of life-threatening airway obstruction. The classic triad is the 3 Ds of drooling, dysphagia, and distress. And radiographs classically show the thumbprint sign, although diagnosis is confirmed by ENT consultation and nasopharyngoscopy.